Welcome to the ICIS Imperial College London webinar today on prostate cancer screening. My name is Anwar Padhani, and you should be able to see Professor Hashim Ahmed also on this webinar. Just to go through some holding slides first, we'd like to thank our main sponsor, which is Siemens Healthineers. You're welcome to sign up for our newsletter. We have an annual meeting at The Hague in September. You're welcome to attend that. And this is our cancer imaging journal. As you may know, we have a number of masterclasses, head and neck, as you can see in this particular instance. But do look at the website and do follow us on social media. Okay, so the first talk will be presented by Hashim Ahmed, who will present a talk on transforming prostate cancer screening. Over to you, Hash.
Afternoon, everybody. Thank you for joining. It's afternoon in the UK, at least anyway. I appreciate everybody taking time out to listen to us speak. So thank you to Anwar and ICIS for inviting me to join this. I think this is going to be the big question over the next 10 years in terms of prostate cancer management, and really very exciting. We've been fairly stagnant in looking at screening, but the last few years and the next decade or so is going to bring a real transformation in my mind to how we look at screening, and hopefully in 10 or 15 years time we'll start to get wholesale approval for screening depending on what our results show. So these are my conflicts, just to let you know. I'm a urologist and I get commercial and academic funding for my work, and I do private work, which obviously benefits me in this field. We have a very large portfolio of studies looking at screening through to diagnosis, treating recurrent disease and metastatic disease. And so we've really been on a pathway of health technology evaluation and assessment over the last 15, almost 2 decades now. So in terms of screening, how do we move the debate on? One of the things we look at when we determine whether screening should be approved, this is screening for any disease, whether it's cancer or not, is whether they meet the WHO or the Wilson and Younger screening criteria. And certainly for prostate, I think we have ticked off a lot of these things, but we still have some work to be done in terms of finding the appropriate tests, finding them to be accurate and suitable and acceptable. We must do better in terms of how we treat prostate cancer once it's found, because I think there's still a lot of over-treatment, and treatment-related harms is a big issue. So even in men who do need to be treated, the impact of that treatment on their quality of life can be so significant as to overpower the benefit of living longer. And any screening program, particularly in one of the largest incidences of cancers that we find with prostate, we need to show cost effectiveness, because we're going to have to look at hundreds of thousands of men every year and millions over the course of a number of years, and that's going to cost a lot. And do the costs of that, the initial investment, the ongoing resource, justify the benefits that we get? We have evidence already in terms of screening, and most of you will be familiar with the European study, which is regarded as the most robust in terms of delivery and the quality of the randomized trial that they did. And that showed that there was a mortality benefit in screening for prostate cancer when using a PSA test and setting that PSA test at a threshold of 3 or 4, depending on which country you were in that particular study. The issue with the European screening study, although it showed a mortality benefit overall, the mortality benefit was only in 2 countries. All of the other countries showed no mortality benefit. And those 2 countries were the Netherlands and Sweden. And therefore, is this something that is only relevant to those 2 countries, or is it more applicable wider to other healthcare settings across Europe in this particular instance? And that is particularly so in that the US study, the PLCO study, didn't show any mortality benefit in screening, but that was problematic because the control arm in that study went off and had a lot of PSA tests. They knew they were in a study looking at PSA testing, and so they decided to go and have the PSA test. So that contamination issue, we feel, might have diluted the effect that was seen, but from screening, because you were effectively getting an organized screening versus screening, but in a very disorganized fashion. And then the CAP study in the UK recently has shown a tiny, tiny benefit at 15 years. But again, such a small benefit that it really doesn't justify the harms, over-treatment related harms, and the costs of delivering a screening program. What are the issues with the CAP study? It was a single PSA test, so there wasn't repeat testing. And again, that was limited as a result of that, and it was probably underpowered consequently. But they had very little contamination in the control arm because they used a cluster Zelen design in which men in the control arm didn't know they were in the control arm going forward because their consent was not sought. So the context that we're faced with now is we're diagnosing more and more prostate cancers, and there is an increased concern about overdiagnosis, the anxiety from that diagnosis of cancer, from a cancer that you may not be harmed by, the extra biopsies, over-treatment related side effects, which are not anything to be scoffed at and can have a significant impact on quality of life. But we have done much better to try and reduce those. So those 3 studies that we spoke about just now were set in an era of PSA followed by a truss systematic biopsy. And we now know from Precision, Promise, and Cochrane reviews of all of the data out there, and a number of studies since, that using an MRI before biopsy can reduce the number of men having a biopsy, can probably increase the diagnosis of significant disease, but certainly reduce the diagnosis of insignificant disease. And so that harm to benefit ratio is getting better. And so we're seeing more MRIs, more targeted biopsies, transperineal biopsies following the randomized trials showing that they are also better in terms of side effects and detection of cancer compared to transrectal biopsies. And once men are diagnosed, we're doing much more active surveillance. Not enough, but we are doing more. We are doing more focal therapy, and we have seen improvements in radiotherapy and prostatectomy. Incremental improvements, not massive improvements, but we have certainly seen from drug therapy large improvements in survival in metastatic disease, where the median survival is now gone from 3 to 4 years to 5 to 6 years in the latest studies. So could this swing the balance of benefit to harms in favor of screening? There have been some pilot studies, and I'll just focus on prostagram, which is the one we did at Imperial, just in the interest of time. But Reimagine, which was led by Caroline Moore from UCL, has shown something similar, although some nuances between the 2 studies. So we, and Anwar was one of our central reporting radiologists in this study, looked at whether a short prostagram MRI, 10, 12 minutes, without contrast, without an endorectal coil, might be better than doing PSA testing as a screening test. So this was a paired cohort design study. We recruited men from the community, and they all had a PSA test, they all had a prostagram, and they all had, coincidentally, an ultrasound as well, looking at whether ultrasound shear wave elastography might be beneficial. which in summary, it isn't in this particular population. And if any of those were positive, we did a biopsy. The participants were blinded to which tests were positive, and the reporters were blinded to the other tests as well. So a very robust design in order to get as much clarity as to how each of these tests perform. And our recruitment target was this red line, but we recruited well ahead of target. Within 9 months, finished recruiting the 410, 415 patients that we needed. What we found was that if you did an ultrasound to find disease in this population, you would biopsy quite a lot of men. An MRI threshold of 3, you would biopsy more than a PSA threshold of 3. But once you started to set your threshold for MRI at a higher threshold of score 4, PIRADS 4 or Likert 4, then you would do a similar number of biopsies to a PSA, but you would find more grade group 2 or higher cancers. We don't know whether all of those are significant cancers now, so the terminology as to how we label detection of these sorts of disease, we try to move away from significant cancers and just talk about the grade of cancers. And as you can see from the bars on the left of each of these graphs, the role of systematic biopsies above targeted biopsies is not very high. And so moving towards a targeted biopsy paradigm in the screening population would make sense. We then modeled out what would happen with various scenarios in terms of biopsy rates and detection rates using this particular patient population. And obviously, these are exploratory analyses. And what we found was that the optimal balance between reduced biopsy rates compared to PSA of score 3 and detection of cancer, we could increase the detection of cancer with doing fewer biopsies if we set the threshold of a prostagram at a score of 4 or higher, but an MRI would only be done if the PSA was above 1. We then spoke to the National Screening Committee about what was needed and what the existing study showed, and they were very adamant that there is still uncertainty about the survival benefits once you take into account all of the studies. There are still too many harms from treatment, that the harm mitigation strategies that I've described, such as MRI before biopsy in secondary care, active surveillance, have only occurred in secondary care in populations that have been referred through symptomatic PSA testing or men going to their GP and asking for a PSA test. And that these harm mitigation strategies could therefore not be automatically modeled to a screening population. You couldn't apply that modeling, the benefits of that, to a modeling strategy where we were looking at screening, because the spectrum or the spectra of disease is going to be very different. And therefore, we need new primary evidence, not modeling evidence, in order to link the mortality improvement that we're seeing from the best study, historically, the European study, with all the harm mitigation strategies that we know we have pioneered, particularly around MRI and reduced biopsy rates, but including active surveillance and including tissue preserving strategies like focal therapy. And then we clearly need cost effectiveness data. If we delivered screening with a prostagram MRI, then these are the number of scans. If we started when prostagram was conceived, this is what the number of scans we would need. And big burden, a big capital investment. We would need more radiologists. Even if we had AI, we would need more pathologists following the biopsies. We would need more urologists, oncologists, support nurses. It would have to be a massive investment. So we do need to know whether it's cost effective. So in that space, Prostate Cancer UK brought us together with the National Cancer Research Institute prostate group when it was still around, that I chaired, and we came together and we conceived of Transform. And this is co-led by my colleagues here, named here, and I'm the chief investigator of Transform in the UK. Transform is a £42 million study, the biggest academic one certainly going forward, and it is formed of 3 stages. The first stage, we're going to be piloting our recruitment strategies and evaluating them. We're going to be piloting a number of strategies for screening and looking at their diagnostic outcomes. And then we're going to be piloting how we can collect tissue in order to future-proof the study against innovation going forward within fluidic biomarkers or genetic markers, for instance, AI tools for imaging and pathology. So that biobank will be critical in order to future-proof what is going to be a very long study. We will then take one of those strategies for screening forward into a bigger study, but that will be reviewed before we do that by the National Screening Committee, as well as a number of other committees from the funders and from the sponsor. And we will then recruit up to 250 to 300,000 men. It'll be a randomized controlled trial, and we will need to determine how we do that during stage 1, and we will look at medium and long-term outcomes. So Transform is going to be a multi-arm, multi-stage platform randomized controlled trial. Men will be invited to have a prostate health check. We may use the term prostate cancer check. We are looking at whether that would work better than talking about a prostate health check. The pilot will start probably in Q3 or Q4 of this year. And we are going to be evaluating what's called a Zelen trial design, which is looking at how Zelen is a pre-consent randomization. And one of the key things we want to do in Transform is to reduce contamination. Contamination will kill this study if we're not careful. And the prostate health checks we are evaluating are very much centered around that graph I showed you of the different strategies of PSA followed by a prostagram, or polygenic risk followed by a prostagram. So PSA of score 3, this is the traditional PSA threshold that all studies have used so far, and we will evaluate this in the modern context. A lot of people are concerned that PSA threshold of 3 misses quite a lot of important cancers, so we want to look at a threshold of 1, which will then be followed by a prostagram. And this is the one that the prostagram study showed was going to perform optimally, potentially. And then a lot of people have some concerns that we're missing some significant cancers when the PSA is below 1. So why not go for a very streamlined, very clean approach where everybody has a prostagram? This is what we do for mammography, so why not do this in prostate cancer? And then a lot of interest in baseline risk attribution from polygenic risk, and that baseline polygenic risk score determining whether you have an immediate prostagram or whether you should have a prostagram 2 years later or 3 years later, and that will be evaluated in arm 4. The Zelen design is quite important in order to minimize contamination, so men are randomized to a prostate health check or a control group before invitation. Those in the control group will not know they've not been invited, and therefore they won't be aware of their involvement in the trial and continue in usual care. Because they're continuing usual care, we're not denying them anything, and therefore it's ethically fine within the context of a screening trial. We are going to learn from lessons in other cancer areas, such as the lung health checks and Flexi-Sig trial in colorectal cancer. And we're going to pilot 2 ways of doing this Zelen type approach. One is to invite men to join a cohort of research and then be allocated. And the other is to be directly allocated to any one of these prostate health checks. I won't go through the details of this, but for the methodologists in the room, this is really quite important that we learn as much as we can from this study. The population will be men aged 50 to 74, but at a younger age, if they are Black or with learning disabilities, where we know the health outcomes in those men are much poorer. No previous prostate cancer, clearly, but importantly, we're trying to minimize contamination by having quite a robust 5-year preceding period where no prostate tests should have been done. We will see whether we stick with that or whether we reduce that to 2 or 3 years. And then we are going to try and drive recruitment more towards the younger age group and try and invite 10% of the population, invite 10% of the invited population who are from the Black ethnicity. And we'll see how many of them agree to take part. I've gone through this already. We're going to be recruiting through GP practices, and we are going to evaluate what the best way of recruiting men will be. And we are working with Shonik Panwani and Anwar in deriving the best way to deliver the prostagram MRI and report it. Once they're referred into secondary care, they're going to have a targeted transperineal biopsy only, no systematic biopsy. And those secondary care sites must have the capacity to deal with the extra work. They must agree to do transperineal targeted only, and we'll be quality evaluating this, quality controlling that. They must offer robustly active surveillance for all low risk and some intermediate risk, and must offer focal therapy as well as radical therapy. And we will check the rates of treatment in each of those treatment arms to make sure that's being complied with. And the first stage, one outcomes, will be looking at diagnostic outcomes, number of men having biopsy, and we will start to model out cost and cost effectiveness, as well as looking at how many men agree to take part. So a really big study. We're going to be starting at the end of the year, but a lot of things to be getting done in the meantime. Very keen to demonstrate our supporters, both academically and our funding partners. And there's obviously a much bigger team around these sorts of studies to whom I'm immensely grateful. Thank you very much.
Thank you very much, Hash. Thank you indeed. Okay, so let me share my screen. Okay, so you should all be able to see this. So Hash has clearly laid out what are his plans. And on the imaging side, there is an imaging group who are mapping out what the likely challenges are going to be. And I'm going to run through those and how we see some of these challenges in prostagram, but in screening generally. So these are my disclosures. So Hash laid out the historic pathway, but also laid out what the role of MRI would be. And that's to basically reduce the harm of screening, as he mentioned multiple times. And he talked about different ways of doing this, the MRI only approach or the MRI first approach, MRI as a second stage, perhaps it's some other biomarkers, including polygenic risk scores. So these are all up for grabs. And if we look at the compare the first stage to the second stage, we end up with this. So MRI as a first stage is there to detect cancers regardless of the PSA level. However, as a second stage, of course, its role has changed into a biopsy triage tool in those people with an elevated PSA. And the PSA, as Hash was saying, will be either 3 or 1. And so we can expect the prevalences to be different. So if you look at the clinical trials, you'll see that the MRI first strategy has a lower prevalence of cancer. And if you're going to pre-screen at 3, we can expect a much higher level of finding clinically significant cancer, if we call it GG2+. And of course, the issues are the balances. So, how cost effective is the MRI first strategy? What are the proportions of men with indeterminate scans? Some concerns about delayed diagnosis if you're going to use a PSA of 3. But the strongest current evidence is in this space as a second stage. And I just wanted to show you that here. So this is the Stockholm 3 MRI study, and you can see that about 12,000 men were invited, about 10% of men had an elevated PSA of 3, and they were randomized between systematic biopsy and an MRI biopsy, a systematic plus a targeted biopsy for PIRADS 3 to 5. And if you look on the right-hand side, you'll see that the MRI strategy in red here, fewer biopsies were performed. You'll see that the MRI diagnosed fewer unproductive biopsies. The MRI had fewer clinically insignificant cancers or GG1s, and there was more or less the same detection of clinically significant disease. So we're saying that the MRI strategy is not inferior, certainly to the standard strategy, which was systematic biopsy. So these are just the data laid out over here. And of course, you can then look at these data and talk about how selective or how efficient the MRI strategy was. So if you took the grade group 2 to the grade group 1 ratio, so if you find a cancer, how much more likely is it that the MRI will detect clinically significant cancer? You can see it's about 3.2 times more selective. It's much more efficient and enables, as we've just said, the avoidance of clinically significant disease. So these are some clinical utilities that you can derive from these measures. And this basically matches up with a meta-analysis that was published last year, looking at over 80,000 men. And you see this is for the sequential pathway. In other words, the MRI as a second stage examination. And as we might imagine, fewer men undergo biopsy, lower detection of GG1 cancers, a higher positive predictive value for GG2 cancers, no difference compared to systematic biopsies, as we've just said. The other interesting thing that came through in this meta-analysis was the number of men needed to biopsy 1 grade group 2 cancer and above. And you can see for MRI that figure is 2, and for systematic biopsy it's 6. So this speaks to the efficiency of the MRI approach. And I think very nicely shows that the PIRADS 4 and 5 cutoff is better than the 3, 4, and 5 cutoff. So that's why we see MRI coming into the screening paradigm and as a second stage examination. And the PRAISE-U algorithm basically shows how this could be incorporated. So you can see an age-adjusted PSA at clinical risk, and the MRI is there to reduce the number of biopsies and of course deliver the biopsy strategy. And of course there's an inbuilt safety net, which is of course the rescreening. Now, when we look at the algorithm on the right-hand side, there are numerous problems for radiologists, and all of us would recognize these. And I've just putting this out there to say that we do need optimization of the MRI, and of course its integration into this scheme. So if we list it out, you can then begin to start to think about MRI protocols. Now, the protocol will of course depend on the role of MRI. So if we're using it for detection or we're using it for biopsy, do we need to think in a different way about what type of MRI that we should be doing? And is 3, 4, and 5, PIRADS 3, 4, 5, appropriate? Or should we be going for something with a higher specificity? In other words, what is a positive and a negative scan? How are we going to deal with scans that are just terrible in quality? And that happens a lot of the time, as many of us are aware. And what do we do with these PIRADS 3 cases? You know, in symptomatic disease, it's about 20%. What is the PIRADS 3 proportion going to be in screening? Do we know? The answer is I'm not sure we know that. So for example, are we going to continue to do this? So a 41-year-old with a family history of prostate cancer, is this appropriate? Should we really be doing dynamic contrast enhancement when the PSA is less than 1? That's an open question. Or do we go for this fast approach where we just get rid of the DCE? That will save time and that would save money. We could, in fact, push it even further, and I'll come back to that in a second. And what is the cutoff that we would use for biparametric and multiparametric? Now, for early detection scenarios where the prevalence of cancer is between 30 and 50%, it makes sense to use 3, 4, and 5 as the cutoff. Is that the same cutoff that we should be using in population screening, where, as I said, depending on which strategy you use, the prevalence could be anywhere between 4 and 20%, particularly if we want to be, we want to think about using 4 and 5 as probably as the favored way of doing it if you want to avoid biopsies and have a higher selectivity for the biopsy strategy. But you could go even further. Should we be using PIRADS at all? Why not just use the T2 and the ultra high B value? And this is the Reimagine protocol. So the Reimagine protocol, quite unique, said no PIRADS. We will just look at high B value images and an axial T2, and we will only have scans that are positive, negative, or non-diagnostic. And the only thing that counted was a focal lesion on T2 and a focal lesion on an ultra high B value, and that was it. Okay, that's a very unique way of doing it. Maybe this is the way to go. And if you look at the Reimagine protocol, and you can see prostagram here, and the PROSAR here, and the MVP study here, that's exactly what they did. You see, they just looked at a focal lesion on a T2 and a ultra high B value. But if you look at their data, you'll see their positive predictive value for this strategy was 52%. So in other words, of every biopsy they did, half of those were cancers. Look at prostagram, 26%, PROSAR, 20%, MVP, 44%. And if you look at the selectivity of the biopsy strategy, in other words, the grade group 2 over the GG1 ratio, this was huge. Look at that, 12 to 1 compared to 2.6, 2, and 2.75. So it looks like this strategy is something that we really ought to be thinking quite keenly about. And then we really need to be thinking about who should be reading these scans and what is going to be the role of MRI, of AI going forwards. Now, here we need to look at the PROBASE and the OPT observations. And what we noticed when you look at these studies, I'm just showing them over here, these studies showed that biparametric MRI interpretation in younger men is particularly challenging, and a lot of us would agree with that. Younger men's scans are really quite difficult to read, and we do tend to overcall them, although the prevalence of disease in younger men is least compared to older men, as a result of which we end up doing too many biopsies in younger men, which suggests that we should really be certifying readers to minimize the subsequent workup of these men who are screened positive, particularly if they're young. Because what we want to do is we want to try to reduce MDT reviews, we want to try to reduce multiparametric MRIs, and we're trying to reduce the number of biopsies. And these regional differences that was shown here in Sweden also speaks to the need to have certified readers. And what about AI? Is AI appropriate? So look at this man. 42-year-old came for a screening examination. Here is the protocol. I put it through the AI. I'm not sure I should have done that. I think it was a stupid thing to do. But look, the AI says the big cancer sitting in the middle of that. Now, of course, that isn't a cancer. But the AI, remember, is being trained on a prevalence of 30 to 50%. So it's expecting half the patients to have cancer. And it goes, here's an abnormality. Well, it isn't an abnormality, right? That is just normal central zone. And I think and it gives it a low score, which is good. It gives it a score of 3, but it was the wrong thing to do. In other words, the message here is do not use an untrained AI in younger men, particularly when prevalences are low, right? And remember, in this setting, we're expecting the prevalence to be between 4 and 7%. So this is the wrong way to do it. So don't use an untrained AI. Okay, the other thing we need to do is think about reducing our workload. We're already doing too many MRI scans in our clinics. Too many people come along for an MRI and require our input. We really want to reduce the total number of men that we send into secondary care to have their biopsies. Can we do something about that? Well, this was actually quite nicely shown by these set of studies, and you can see you can use a second biomarker following a PSA test. So you can either use the Stockholm 3 test or a 4K test. And if you look here, you'll see you can reduce the total number of MRIs by quite a lot. So it may be that we need to think, particularly going forward, about interjecting with a second test after a prostate, after a elevated PSA level. The next thing we need to think about is what method of biopsy should we be using? Should it be a targeted biopsy alone? Should it be a targeted plus a systematic biopsy? We know that's going to result in a higher prevalence of clinically insignificant disease. Or should we be using the new EAU standard, which is regional targeted biopsies or peri-lesional biopsies? Same thing. How much data is there to support that? Well, the Gothenburg 2 study looked at this. Quite interesting. Again, they looked at about 18,000 men. You'll see about 7% of these men had an elevated PSA. And then they were randomized to a systematic biopsy, or they had a targeted biopsy alone. And if you look on the right-hand panel, you can see that MRI reduces the number needing a biopsy. This isn't a surprise. We've already seen this with the Stockholm 2 study. But look at the number of men having no cancer with the MRI targeted biopsy alone. That's the least. You can see that unproductive biopsy is highest in the systematic biopsy, followed by systematic plus targeted, but being least in the MRI targeted biopsies. If you look at indolent cancers and the detection of indolent cancers, GG1s, again, it was least with the MRI targeted biopsy. But look over here, can you see this? Grade group 2 plus and above. You can see that the MRI targeted biopsy does result in slightly fewer men having clinically insignificant cancer. Now, is this a generalizable observation or not? It turns out this probably is a generalizable observation, because if you look at the Gothenburg 2 study, you'll see that the added value of adding systematic biopsies for grade group 2 detection was 5%. For the Stockholm 3 MRI study was 7%. For ProBase, it was 7%, which is interesting. So there seems to be some added value for doing systematic biopsy, although the meta-analysis showed no overall value. But these are 2 randomized trials, so I think we really need to pay attention to the randomized studies. The interesting thing is the majority of these missed lesions are small. Because if you look at the PIRADS-4 proportion, you'll see it's at 15%. If you look at the PIRADS-5 proportion, it's between 4 and 7%. Let's round that up to 5%. So in other words, the cancers with the GG2 plus cancers that we are missing tend to be smaller, i.e. PIRADS-4 lesions, which is why they're getting missed on a targeted biopsy. The other interesting observation, of course, is that a lot of these people had a low percentage of grade group 4 disease, sorry, Gleason pattern 4 disease. In other words, a lot of these people were likely to be suitable for active surveillance. So we probably don't do any harm. So that maybe is a question for Hash towards the end of this conversation. What biopsy strategy should we be thinking about in these particular settings? So what can we conclude from what we have been able to discern? Certainly from the cost perspective, second stage MRI may be the preferred choice. We have randomized control trials to support that assertion. We certainly need to have reliable and reproducible protocols, particularly for these low disease prevalence settings. So they need to be short, simple, and fast, maybe even just single plain and no IV contrast. In terms of the reading criteria, I'm not sure PIRADS is the right scheme. I think Reimagine might even be better. And if we're going to use PIRADS, maybe we just stick to 4 and 5. We really need to be thinking about minimizing MRI interpretation variability, which seems to be affecting younger men. So maybe we need centralized reviews, dedicated readers. We need to be documenting reader expertise much more carefully. And then how do we integrate this MRI into the screening pathway in something that's much more cohesive? Thank you very much for listening. We'd be happy to take any questions in the chat.
So Anwar, I think the chat is not working for people, so they are putting questions in the Q&A box.
Okay, let's go to the Q&A.
So if people are struggling with chat, you can go into the Q&A, I think. So probably one of two of us or both of us can take this. Can you clarify the difference between early detection and population screening?
Why did you do that?
So early detection is a part of population screening, but population screening is effectively where you identify a group of people who you want to screen for a certain disease, and you approach all of them routinely. A letter goes through the post from your GP, from the government, and says, we have a test for you to have to check for X disease. And so it could be, breast cancer, you have population screening for colorectal cancer, but also other diseases as well. Early detection is a part of that, but early detection is more about trying to engage people to come forward when they have symptoms and go to their GP if they have concerns, particularly if they are so if they have some risk factors, whether that be age or family or other things like dietary habits or social habits like smoking, or where we encourage general practitioners to take proactive measures. So when they meet somebody for something else, they ask them about bowel change, they ask them about a cough or other symptoms. So they are sort of married, but the population screening is really much more widespread if we do carry it out.
The other thing to mention is who benefits. Yeah. So for population screening, it's the population that benefits, and that's the primary role. And everything is geared to a population benefit. whereas early detection settings, the prevalences are much higher, usually 30 to 50% compared to the lower prevalences in screening. And the person who benefits is the individual rather than the population. So there are differences and nuances.
It's a really crucial point because we see emotive stories on news, on media about individuals, and an individual diagnosed at an early age with a family history, leading to lots of young men in their 30s and 40s having a PSA test, having an MRI scan, uh, can actually lead, unfortunately, to harm. So we have to be really careful about individuals are very important, but for screening, we have to look at the benefit to society, and because there is a very significant cost issue.
Yes.
Anwar, why don't you take the next one from Lisandro Paganini? Hopefully, I pronounced it correctly.
From Argentina.
Argentina.
Thank you very much for the question. So how do you apply this evidence into daily practice? Well, this is the problem, because of course, the question really is screening ready for daily practice? And I'm not sure that the evidence beyond one corner of Europe is strong enough to recommend screening as a general tool for the population. What do you think, Ash?
Yeah, I mean, as I said, I think the evidence is still uncertain, I'm afraid. There are plenty of people who say that the harms are still too much, and by screening, we're going to cause even more harm of biopsy and overtreatment. And then there's the other side of the spectrum. As we get better treating advanced disease, mortality improves. And whatever delta we're seeing between control and a screening arm might be wiped out because we're just treating better and men are surviving longer with systemic therapies. The advancements, like I said, have increased median survival by a few years. That's enough potentially to wipe out any delta you see between those two Kaplan-Meier curves. So we're going to have to work really, really hard and follow up men for 15, maybe 20 years to see a difference. And each decade that goes along, standard care treatment for advanced disease, for significant disease, gets better and better. And we're having to struggle against that. So, for those who want to see screening now, I'm afraid the evidence is just not strong enough. And we do need studies like Transform.
Yeah. So Hash, so if the screening committee is going to insist on a mortality benefit, will they not look at the flip side, which is the harm reductions?
Yeah, I think they will look at it from in their complicated modeling. And one of the issues they have about more, other surrogate endpoints like metastases-free survival is we're not very good at measuring that in our national registries. And if we go for a Zelen design where it's effectively a passive control, how do we know what's happening to those men? How do we know when they're developing METs? Because it's not documented unless you go right into the notes of each individual patient. And also, if you look at PROTECT, PROTECT showed a metastasis-free survival benefit when you treat, but that didn't translate into a survival benefit when you treat above active monitoring. So they are arguing maybe metastasis-free survival in this particular population isn't a good enough surrogate for mortality, and therefore we need mortality. They will obviously look at the harms of what's happening now, the harms of men being diagnosed late and having really, sort of kitchen sink type approaches thrown at them. That's a harmful effect that could be reduced by early diagnosis and having more straightforward treatment. And again, that needs to be all teased out and measured. The
So,
so Anwar, what about age?
I
do you want to tackle the age upper threshold? You spoke about lower threshold, upper threshold.
I mean, I think you've spoken about this multiple times, but I think Danny Boxer, brings up a valid point. Why 74? Why not older age or,
Yeah, you have to look at the UK life expectancy, and yes, it is getting better, but not that much better. So on average, men are surviving 80 to 85, 86 maybe in affluent areas. And so what benefit are you giving that man who's got a few years to live when he is being screened at the age of 75, 76, 77? Um, we could do it if we had a robust way of measuring competing risks. There are some tools that general practice is using, but they're not that great in terms of determining competing risks to mortality. So we wanted to actually stop at 70, and our patient reps and a lot of debate later within our trial management group, we decided to go up to 74. But I think once you start to get to those other upper age thresholds, you don't really see a benefit from screening those men.
yeah, you may not get a mortality benefit. That's your answer, Denny. So we've got another question. Do you find AI helpful in your daily practice as an experience, or was it better for the inexperienced? Okay, so this is going a little bit off topic, and we've got a little bit of time. So unless there's another question about screening. Okay. So let's get the first answer. Well, AI certainly for prostate cancer diagnosis is certainly emerging. And we know that the best AIs will actually beat the radiologists, and certainly one of the biggest problems with radiologists is specificities all over the place. And certainly we can say that that AI as standalone beats radiologists in general. The issue is when you give a radiologist an AI, how much does that performance increase? And the answer is not a lot, or not enough. And that may not justify the cost, but if you were to compare inexperienced users and experienced users, then you find that the AI is definitely helping inexperienced users. So yes, AI is helping inexperienced users, and I think the data there is quite robust. And there are large multi-reader studies that are all in press coming through, and I think that will show it. But for experienced readers, maybe it doesn't help that much. And then the next question was, are there any robust recommendations for preparing patients for a short MRI? So clearly, patient preparation is a key thing. One of the questions that we haven't quite sorted out in the Transform study is about how we're going to prepare men for their MRIs. Are we going to insist on mini enemas? Are we going to ask them to refrain from ejaculation? Are we going to use Buscopan? Probably not is the answer to that question. And one of the ways we can improve quality is to use these deep learning reconstruction methods, and that certainly seems to make the scans go much faster. And these DLR sequences, which are now beginning to be rolled out, I think will help to improve the quality. But there are, as you say, that there are a number of basic quality issues. And clearly, if you've got a non-diagnostic or non-optimal MRI, then within Transform, there will be one chance to return for a repeat scan. Did you have anything to add to that?
No, Anwar, what's the evidence around low residue diets? I mean, we used it in prostagram but we still had a few men who, you know,
There isn't
needed repeat.
much evidence at all. There isn't much good evidence around this. This is the problem. There does seem to be a number of studies that do show that mini enemas can be helpful. And I'm convinced of that. But then that adds an extra cost to the whole exercise. And I'm not sure that we will introduce that in Transform. And then we've got another question on AI. Do you think it'll, given the shortage of trained radiologists, the answer to that is yes, probably, but that depends on the workflow. There is no doubt that if you have an AI assisting you, whispering in your ear, that can often lead to more work for the radiologist, believe it or not. And if you look at the workflow, time workflow exercises there's hardly any time savings. AI as a second reader seems to increase the number of false positives, but there are other workflows which I've written about recently in European radiology that seem to give some efficiency savings.
Can I just say on that front, I think needs to be a huge amount more focus on this area, because this, for any industry or academic researchers on the call for this, really focus on this. And just to say, the prostagram MRI scans and clinical data are freely open now, open access. So if anybody wants to get access to that, please do let me know. And there's already a few academic and commercial people who are looking at that data, and we want it to be used for patient benefit as quickly as possible.
And the next question is, do you support the use of biparametric MRI for screening? And should, if you had to implement it today? The answer to that is yes, absolutely. I think the contrast medium in the screening setting is a nightmare, because all you do is increase the proportion of PIRADS 3 and indeterminate scans, and you will just end up biopsying so many patients. So if you're going to adopt screening now for your population, then biparametric MRI and use a threshold of 4 and 5. Don't use 3. Don't do that.
And you're going to have all of the problems with healthcare burden, medical supervision. You're going to have, if you're screening millions, you're going that low percentage chance of anaphylaxis starts to become very relevant if your screening test starts to kill off a few men. So you have to take that into consideration.
And then another question, Hash, from Gianni. From a practical point of view, do we still rely on a PSA of 3 if the DRE is negative to perform an MRI? Can biparametric MRI be used as the standard? So this, Hash, this is back to you.
Yeah, so 2 questions. We don't really do DREs anymore in the UK. I think a lot of GPs have stopped doing it. The evidence shows it's not very useful. It's not very sensitive or specific. That might be a training issue. In secondary care, I don't even see the patient before they have a biopsy. I mean, they go through so quickly. And only if a man does not want an MRI scan will I do or advise a DRE, because there's no way my finger is better than an MRI scan. So that's one question. Biparametric MRI, again, Anwar has summarized the data in numerous talks and publications. Clearly in good hands, with good quality, it performs as good as multiparametric MRI. We are recruiting to Pacific at the moment, which is a 3,000 patient randomized controlled trial, randomizing between biparametric and multiparametric MRI to see in actual clinical practice what happens to biopsy rates and rates of P3, 4, and 5, and then subsequent cancer diagnosis rates. So we have recruited about 1,200 to 1,300 already, so we're well on our way, and that will really provide the definitive evidence to either stay with MP or switch to biparametric in standard care.
Maybe we can just squeeze one more question. We're running out of time. So there is a question about who is the ideal target group for screening. So what do we do today with these higher risk men? Family history, Lee-Fraumeni syndromes, BRCA mutations. What should we be doing today to these people?
Yeah, so the National Screening Committee is currently doing a review of its guideline, but I think they're doing a particular focus on those higher risk individuals, so Black ethnicity, family history, and others that you can. I mean, the national and population impact of screening those men, if you are looking at mortality rates, is going to be very, very small. The question is, for that small benefit, if there is a benefit, is it justified to put resources into that? How do you find men with family history? Most of them don't even know, or if they do, then so how do you contact them? How do you find them? There's no simple way of doing it. Black ethnicity, not all men will declare that on their GP practice. So you're going to have to invest in lots of awareness campaigns. Government's going to have to spend. And ultimately, apart from the really high risk genetic predispositions, we don't know whether actually screening these men versus no screening benefits them in terms of harms, and mortality benefits. So we must be careful that we are not too emotive when it comes to screening decisions. Screening, as Anwar said, the take-home message from this is it's a population benefit. And if we're not seeing benefit on a population level, then screening is not justified. So we need primary evidence in order to derive our guideline recommendations.
Okay, so there are lots more questions. I'm sorry we can't keep going with this. We're past our due date, and my secretary is already saying we need to curtail this. So thank you very much, everybody, for attending. Thank you, Hash, for co-hosting this webinar. I think I thoroughly enjoyed it. Before everybody goes off, we would be very grateful if you could put in the Q&A your country of origin. Some of you I recognize, so I already know where some of you are from. But for the rest of you, please put your country of origin. And thank you very much for attending this webinar. Thank you.
Thank you, everyone.
Thank you, everybody.